So this brings us to the Extend IA trial. This is an Australian trial, and this takes the roles of imaging and patient selection even further. And so this was the smallest of the trials. And what this actually looked at was the ability to use software to predict the core infarct volume. So they're actually doing quantitation of that infarct volume, and also the salvageable tissue of the ischemic penumbra and how much would be available to you. And so again, you can see here that the imaging criteria look relatively similar, except when you get to the imaging, which is not only do they have to have a higher aspect score and obviously CTA revealing an anterior circulatory occlusion, but you also have to have a significant amount of mismatch based off of the Tmax, greater than 6-second delay in terms of perfusion. And so what you're looking for is a mismatch ratio of greater than 1.2, and then an absolute mismatch volume of greater than 10, or an infarct core less than 70. So this is important because these types of imaging criteria are going to then be used for subsequent studies, such as the diffuse trial, which we'll talk about just toward the very end of the study or of the presentation. So here's the randomization schedule. Again, it's a much smaller number of patients, but even in the small number of patients, here's the patient-line characteristics. So again, you'll notice that the stroke scale is a little higher on the intervention arm, but nonetheless, that would weight this actually to be having more deleterious effect. The medical comorbidities are comparable. So here are the baseline cores in terms of the actual stroke volume. So it's about 20 mLs in both. And again, the M1 is the most common location. And here's the baseline perfusion lesion. So you can see these are quite similar. And so in terms of time, you can see here, these are the time intervals to completion. And so again, they got this, the time to grain puncture is in this case under 4 hours, but again, that's a pretty good target number in terms of how long it takes to randomize a patient. We'll get faster than that, and you'll see that in a second. But in terms of the time to arrival to TPA, less than an hour, which is very, very good. In terms of the recanalization rates, again, comparable to SWIFT Prime in terms of those numbers, close to 90%. And then, of course, the modified ranks at 90 days, very, very high in this case. And again, that's in part because they're really picking winners here. They're using imaging to really select those patients who are going to derive the most benefit from intervention. So here it is at 90 days. It drops down to a number needed to treat of only 3, which is wonderful. And again, here's the infarct growth data, and just showing that in the IVTPA arm, obviously their infarcts grew because obviously they're not getting recanalized at such a high rate. We already kind of discussed that at the beginning of the case. From a safety standpoint, again, the death rate was actually lower, not significantly so, again, because this is a smaller trial, but nonetheless, the all-cause event rate for serious event rate was good. The last trial was the REVASCAT trial. This is a Spanish study, and what this did was kind of comparable kind of imaging criteria and selection criteria to Mr. Clean, but what it did was it expanded the time to intervention by an additional couple hours, up to 8 hours. And so this is, again, a multi-center study. It's blinded to outcomes as well as imaging assessments. And you can see here, it's the same type of setup as Mr. Clean. It's just a slightly longer age range or time range. So here's the randomization schedule. And again, here's the number of patients that were actually evaluated. So here are the baseline patient characteristics. You can see they're relatively comparable in terms of their stroke scale, their age, and obviously their aspects. Slightly lower aspects than some of the other trials. So note here, 7. And again, most of the patients have M1 occlusions. Again, time to grain puncture is going to be longer here again because we're just expecting that these to be slightly longer in the event that we're allowing for patients to have kind of a more delayed presentation. But again, we still had higher rates. Better than 50% of patients were getting some TICI-2B or TICI-3 results in terms of the recanalization rate. And again, their stroke volumes were significantly lower. You can see here relative to the control arm. And here's that same plot that we've seen with all the other studies, just showing the impact of thrombectomy relative to IV therapy alone. And here's the adjusted odds ratio for those patients at 90 days. Again, no difference in terms of the major symptomatic event rates. Again, we do see this kind of effect where you can get emboli into different territories as part of the intervention that you obviously wouldn't see in a medical therapy, but ultimately the death rate's slightly higher here, but and even higher at 90 days. But nonetheless, REVASCAT also was, a positive trial in the sense that it showed that, intervening on these patients inside 8 hours can be effective in the anterior circulation. So that brings us to kind of part 3. So here's the summary data. So this is all of it kind of put in one place. And this, I'm just trying to highlight here. Here are all 5 studies that we just talked about. And here's the modified Rankin information at 90 days. And what you can see here is that in the control arm, intervention was superior in all of them. The ESCAPE, the EXTEND, and the SWIFT prime studies all use some element of advanced imaging beyond just CT and CTA. And you can see how much more often those patients would have a better outcome. But nonetheless, even without those elements and in the ability to include these patients are still receiving benefit. So it is not to say that we should just use advanced imaging to exclude patients who might otherwise could receive benefit. And so I think that's really important there, and I'm trying to just underscore that on that slide. So in terms of the elements of time, here on this side is the percent in terms of whether you got a good recanalization rate, what your modified Rankin is, and so this has to do with how effective a study is, and then this actually is the element of time in terms of minutes. And this is time from to groin puncture. And what you can see is the effect is larger. So here's the control group and here's the experimental group in terms of modified Rankin, as you are earlier in that time frame. And it's smaller out here in the patients that were took longer to get patients obviously in the angio suite. But again, these are also 2 studies that did not use advanced imaging as much. But again, there's still a measurable and significant effect here. And so these 2 paradigms, if this is, for example, is a comprehensive stroke center or a primary stroke center that can do things, these patients may be coming from outside, and this kind of calls into that space of what we call the trip and ship. So the idea that these patients could be seen at another location where they could receive IVTPA and then transfer to a higher center where an intervention could be performed. These patients will still receive benefit, and that's still very important. So this is an image from the Mr. Clean study, but what this is just showing is that this is the effect of time on reaching modified Rankin in all participants. And so there's a 6% decrease in the absolute risk difference in good outcomes, so modified Rankin of 0 to 2 for every hour delay in reperfusion. So every time that what you're saying is that as you extend the time, no matter what's going on, you're meaningfully going to decrease the ability of that patient to have independence in the short and in the long term.